people don't really think about microcirculation enough, and the effect that it's having on the kidney, the eye, the brain. And by the time it shows up, it's really impacted function. And programming arterial health, depending on that person's genetics, family history, their risk factors, should start at an early age. That is, I'm not saying aggressively manage lipids at an early age. What I'm saying is already know where are the variables that would influence arterial health in this individual, and programming holistically for those variables and monitoring them. Now, one question I had that wasn't on your list is, had he had a lipoprotein A checked yet?
Yeah, he didn't send me all of his labs, and he had a small particle analysis done, and but he didn't know what his LPA was. So I'm sorry, sir, could provide that.
That's okay. It's actually, at this point, he's got the disease. And so it's less crucial than when you're trying to prevent the disease. But and now with the new study that was released on ApoB lowering for people who have arterial plaques and the clear reduction in risk of event and death from arterial events, that, any cardiologist is going to manage the ApoB to under 50. Like that's where they're gonna measure LDL, but ApoB is what should be actually managed. And so, these are cases where with this much disease, yes, the medication interventions have potential side effects and downsides, and not everybody can take them, but you got to look at this as this is the primary factor that's going to influence his longevity, arterial health, right? Because he's got disease. And he's already had a stent. More than likely, the kidney is a circulatory issue. It may not just be that, but more than likely it is. And so going ahead and being aggressive around all the variables that influence arterial plaques is really important in a case like this. It might be that later you can back off. So one thing was lipoprotein A, because that might inform ApoB target with drug therapy, which can include statins, steroid blockers like ezetimibe, fibrates, depending on triglycerides, HDLs, others. High-dose niacin is actually one of the only therapeutics that's been shown to lower lipoprotein A. There are just no outcome studies on it. But if you look at lipoprotein A functionally, there's a reason some of us genetically code for it. I'm one of those. It scavenges oxidized lipoproteins. And so I have seen in my patients, because the thought is check it, and then if it's above the range that the risk acceleration curve starts, which is 50, but there might be some risk to like a 30 to 50. If it's 15, then you leave it alone. You don't need to check it. If it's not detectable, the person doesn't even express it. Good for them. Probably about 15 to 20% of people will express it. Now, with lipoprotein A, every one of you that is doing any type of more comprehensive health evaluations on individuals should screen lipoprotein A on every patient. It's a $4 test. And if they have it, again, and you're not going to necessarily aggressively intervene, but you'll start looking for pathology sooner, possibly coronary calcium score. Instead of age 50 in a man, you're looking at age 40. Other implications of high lipoprotein A, though, aren't just arterial. It's aortic valve calcifications, which can lead to aortic stenosis and blood clots and stroke risk. So there are other reasons why you would look at it. You'd never tell someone to be afraid. I don't live in fear because I express lipoprotein A. I just am very smart about making sure that I don't see any signs of disease development. And I would use a medical model if I needed to manage for those, because it really can influence. But what I've seen is that when, the oxidative stress environment is not good, the endothelial environment is not good, that, you'll usually be able to measure an elevation in oxidized LDL. A better long-term measurement for that is oxidized phospholipids on ApoB, which Boston Heart will offer. Oxidized LDL is really telling you what's going on over a few days a week at the endothelial level, whereas oxidized phospholipids is more of a weeks to months marker, right? And if it's elevated, then we've got an oxidative stress issue and it's affecting the endothelium, and I need to push in with whichever strategies that I'm going to use. And so the other test that I was going to suggest, if you can get it, would be a carotid intimal medial thickness screen, because that's actually measuring the endothelium, right? The thickness, and can show, is there plaque? Most people are at this age are going to have some plaquing at where the carotid bulb is, at the carotid bifurcation, because it's a high turbulence area, high pressure, high turbulence. So we don't really freak out because there's a couple millimeters of plaque or something in that area. What we want to look at is the plaque nature. Is it calcified? Okay, good, healed. Is it heterogeneous? Well, it's actively healing. Is it soft, fresh, right? Is this active? More important is the measurement of the intimal medial thickness, because atherosclerosis will start behind the endothelium before it's ever plaque extruding into the surface. It's actually developing behind the endothelium. It's actually a compromise in the tight junctions of the endothelial cells and a deterioration of the glycocalyx, protecting those endothelial cells. And so if you can maintain good tight junctions and a good glycocalyx, theoretically, you shouldn't have endothelial dysfunction. Nitric oxide signaling is critical. But I would think about a CIMT because that would tell you whether, I mean, it won't tell you definitively, but it can give you more evidence of, is there an endothelial problem right now? Right, that I can address. And it's also changeable. Like when we do interventions on patients where we measure that, and this could include 40-year-olds that don't have, they have a coronary calcium score of 0, but they have endothelial dysfunction. That's critically important. And so we will go ahead and maybe it's just nitric oxide support. Their NOS enzymes aren't working great. And we want to come in with nitrates, but also maybe a little bit of NOS catalyst as well. And we improve that. And then we remeasure in 6 months. Or we go ahead and add arteriosil, red algae derivative, glycocalyx support. And we commonly see that IMT has shifted in a positive direction in 6 months with just like natural endothelial support options, not even, using statins and drugs like that. And the right patient, statins can be great, but you've got to monitor their because it can be very subtle myopathies. And then there's the cognitive impairment, which I personally believe has to do with cholesterol synthesis in the brain. The brain is dependent upon synthesis for itself. It can't take up lipoproteins from the blood. And so therefore, if you inhibit central nervous system synthesis and myelin is 70% cholesterol, that's where you could end up possibly with some, changes. Boston Heart offers what's called a cholesterol balance test that will measure plant sterol absorption, but also measure lithosterol, desmosterol, 2 of the markers of cholesterol synthesis. So you can see if the person is potentially hyperproducing. Now, they might be hyperproducing because they just had surgery or they just were sick. So you can't just say, well, that's okay, this person's just a hyperproducer forever because that's you. The context that you ordered is important. If they're stable and there's nothing going on and they're a hyperproducer, well, and they can tolerate statins and they really have serious risk of arterial pathology, well, that's what statins will do. But you can monitor the desmosterol will index more to brain cholesterol synthesis. So you can monitor and make sure that, you are inhibiting synthesis, but you're not over inhibiting brain synthesis so that you know that you're not depleting the brain's ability to create its own cholesterol and maintain myelination. All right, so that's a lot, I know, but essentially, I had this because I had to just do this quick, and we're going to talk through it so quick, and it's so important. This is a more detailed PDF, right? That goes, and so Leo will make sure you all have it and you can read it. I don't want to just read it to you. We've already talked about endothelial function and microcirculation. We talked about the fact that there's a mucus layer, a glycocalyx. It also is proteinaceous that is buffering, basically a friction buffer to kind of protect and nourish the endothelium itself. The endothelium is 1 cell layer thick. It's fragile and it has tight junctions. And those tight junctions are critically important. There's a lot of things that actually influence tight junctions. Lipopolysaccharides from the gut is a big one. They're beginning to recognize that LPSs could be a major contributor to arterial disease, to atherogenesis. And in course, addition to glycemic variability, surges in glucose leads to glycation. That glycation, if that endothelium is exposed, is going to damage it, and it's damaged its own repair capacities. As we age, our nitric oxide synthase system doesn't work as well. We can look at the genetics and maybe predict a little bit about who would need intervention sooner or later, but that's where you come in with nitrates from different sources, whether that's a dedicated product like Berkeley Life or it's beetroot or something else. You just got to make sure you get the dosing right. You can actually assess this with a salivary test and know, is my strategy for maintaining adequate nitrate to nitrite availability for nitric oxide effective? I can't tell you how many times the 50-year-old came to my practice and they now have borderline hypertension and they stopped me near the end to say, hey, could I get something for erectile dysfunction? They're sheepish about it. And then immediately what I'm thinking in my mind is, has this person had a decline in nitric oxide availability? Especially if they're fit, they're not overweight, they don't have insulin resistance. And we will intervene with a strategy to support nitric oxide availability. And what happens is their blood pressure normalizes and their erectile dysfunction goes away, right? So it was clearly a circulatory problem, but not just major artery microcirculation, which I believe is commonly missing because we tend to think about stroke risk and heart attack risk and then forget about ED is usually a circulatory problem. It's often the canary in the coal mine that there's a microcirculatory problem. And then the eyes, people over 50 should get a retinal exam periodically and actually look at the vascularity of the retina, because if you start getting microcirculatory disease there, it can be irreversible and permanently affect your vision. And it's preventable, right, to some extent, or at least you can delay it a long time. The kidney ties in perfectly. Now, we can't say that it's 100% a microcirculatory issue, but I would wager that it is in a case like this, because if he has substantial arterial plaques, then he's got, microcirculation has been impacted. And, some of the things here, like, the very subtle endothelial injury can impair the autoregulation of the kidney, oxygen delivery, and glomerular function. And so this is could be a residual ischemic injury from when he had an MI. Maybe not. Maybe he maintained perfusion, but also probably reveals microvascular dysfunction that was present long before the event. I've already talked about nitric oxide. Again, salivary strips. You can order these things cheap, and you can do the test right in your office. Just make sure they haven't just drank anything or chewed gum. They got 10 or 15 minutes. They put it on their tongue and get it wet with saliva for 10 seconds, and you pull it out and you immediately compare it against a card, and it'll show you not nitric oxide status. That's critical to know. You're not measuring nitric oxide. You can't, except in a research lab. It's a small gas and it's metabolized incredibly quickly. You're measuring nitrite availability, one pathway for nitric oxide. And if they're low in that, and they have potential microcirculatory or endothelial dysfunction, then addressing nitrites is an easy thing to do that will reboot the system, so to speak, and actually improve NOS enzyme function as well. So then the other pathway is catalyzing NOS, which is typically done with L-citrulline and or combinations of beta-alanine, or some people take arginine. It's better just to skip and go on to citrulline. What I'll typically do is, especially for people who are training, I like to optimize both if appropriate. So I'll typically always start nitrite, because if NOS is decoupled, you could actually end up, through loading it, you could actually create peroxynitrites instead of nitric oxide. And now instead of creating an antioxidant, you've created a pro-oxidant. At high levels, nitric oxide is a pro-oxidant. And it is used by your immune cells to kill microbial species that need to be killed as a pro-oxidant. But your body regulates it well. So if you optimize substrate, that doesn't mean you're going to just produce nitric oxide. Your body will still regulate it. What it means is when your body sends the signal for nitric oxide, it will actually have what it's needed to make it, right? Which is very important, because as we age, the research is clear. Nitric oxide capacities reduce, and then arterial health issues start. So autonomic nervous system, critical. Like, it's so clear that people who are in sympathetic dominance, which is most people, that is a major influencer of arterial plaques.
Most hospitalists.
What's that?
Most hospitalists.
Yeah, exactly. Exactly, right? Like, it's critical, but the problem is it feels more abstract to the patient. It's been entrained. It's like their thought feeling kind of environment. A lot of people who are real positive people, I'm one of those, can use positive psychology and mindset work to entrain and reinterpret all this excessive demand we're putting on ourselves and all these responsibilities. We can actually entrain like a positive narrative around that. We're doing good work. We're making a contribution. We're making a living for our family, all this kind of stuff. And the bottom line, though, is that deep down in the kind of non-conscious areas of the brain, it doesn't care how you're narrating it. I mean, the narrating does affect it. It's helpful, because if you're also interpreting it as I'm so stressed and I have no control, that's going to worsen the situation. So that's an overstatement. But at the end of the day, it's either going to click into threat state physiology or safe state physiology. And I would wager, I can clearly see the patterns with metabolomics testing that people are sympathetic dominance, and it's like 100%. At this point, whether they're chronically sick, which would create its own stress when they come to see me, or they're an optimizer wanting to be more optimized, because those people they expect too much out of their body, especially with aging. And they're hoping they can use a big stack of peptides and molecules and just continue to run marathons every month or something. And there's a point where you've got to recognize that exercise is really good for you. Fitness is important, but it is a hormetic stressor that can become a negative stressor when you're overdoing it. Actually, endurance athletes will have higher rates of arterial plaques due to the oxidative stress that develops in the myocardiocytes from that sustained high demand over a long period of time. So we could, again, spend hours on this, and we don't have that time. But autonomic nervous system will come up over and over again. They could get heart rate variability assessments. Heart rate variability can be deceptive as a sole metric. Fit people might have what appears to be a normal HRV, but if you use an app that breaks it into frequency inputs, you'll still see the clear pattern of sympathetic dominance. Like I said, we can see it biochemically with metabolomics too. And no, it's entrained. And so they need to accept that it is playing a role and they need to have a plan. And you know, it's environmental, it's time outside, it's spiritual practices, it's breath, it's critical. If it's not being addressed, we're swimming upstream. We'll make progress addressing these other aspects of the symptom. We'll actually get upstream a little bit, but we're going a lot more slowly if we're working against a nervous system that's programmed into threat. Vagal nerve stimulators could be appropriate. You know, I think you've already got some of this, but would look at ApoB, lipoprotein A, fasting insulin, homocysteine, uric acid, omega-3s, cystatin C, urine albumin. Like these are sets of labs that we would do in a case like this to really make sure we've done an assessment. CIMT, I already talked about. And then renal protection, kidneys should be viewed as a vascular organ. So we want to increase intraglomerular glomerular pressure. We want to improve endothelial function, improve renal perfusion, optimize metabolic health, minimize insulin resistance, avoidance of nephrotoxic drugs like NSAIDs and others. And then, with cystatin C, it's a more direct way of monitoring kidney function and kidney stress. And right. it will move. And so it's really helpful to look at that and not just look at GFR, which could be affected by how hydrated they were that day, what was the BUN. Protein insufficiency will worsen kidney insufficiency. But yet, if you have kidney insufficiency, you'll be told be careful about nitrogen load, right? Because we clear nitrogen through the kidneys. And if you have a heavy load, then your nitrogen clearance could be reduced, and that can create problems. This is where I think essential amino acids can become great for people who need a higher protein target, because they've got to have what's needed for repair. Like the kidneys are working all the time. They have a big demand for enzymes, proteins, essential fatty acids to maintain the health of those cells. So you've really got to optimize essential nutrients, including macronutrients. And what I'll do in cases where we have to be a little more conservative with the protein target is add appropriate doses of a properly formulated essential amino acid supplement, which increases substrate for protein synthesis without increasing nitrogen burden. That's the beauty of them. You can add them in and you won't do that. Now, we'd have to talk about GLP-1s in this case, right? Because GLP-1s actually have FDA approval for renal protection and heart protection, even in patients who don't have diabetes, prediabetes, or weight problems. Now, what we don't want to do is if the person doesn't need to lose weight, is go be aggressive on dosing at all. We would stay at the lowest dosing thresholds, but they're also anti-inflammatory. It's reasonable to consider with somebody who has coronary artery disease and renal disease that you might consider a GLP-1, provided it's reasonably indicated. Also, medically, SGLT2 sodium glucose transporter inhibitors, which work through blocking the transport of glucose back into the bloodstream. They actually are highly renal protective, independent of diabetes status. They are expensive. These would be medications that they'd want to get their insurance to cover. But for a lot of insurers, if there is renal disease, they'll cover them because renal disease is incredibly expensive once it progresses. Mentioned essential fatty acids, membrane health, phospholipids, AMP-K, mTOR balance. This comes up over and over again. This is foundational. This is every case, right? These influence membrane fluidity, inflammatory signaling, endothelial function, autonomic regulation, vascular resilience, and more. So I would get an omega-3 index and I would correct any deficiencies. The only thing to watch for is a lot of the omega-3 supplements, and you got to make sure quality is good. You got to get reputable brands. Do stack EPA much more than DHA. And actually what you really want is ratio DHA maybe beyond EPA because of membrane fluidity. EPA can be powerful as an anti-inflammatory, but very high levels of EPA have an association with AFib. And so somebody who already has coronary artery disease and had an MI, who even though structurally he looks normal, he probably has some structural disruption that could affect his conduction system. He's got higher risk of AFib. So you wouldn't want to run EPA up too high. Like you'd like to get it optimized, but not run it high. So you might look at an algae-based, which is already ratioed to DHA over EPA, but then you would need to dose it. Critical that that's being addressed. And then, this is acknowledging the stress environment. And so restoration of metabolic flexibility, AMP-K activation, which actually helps. So berberine has some soft evidence and that berberine can influence AMK activation. Berberine actually has some soft evidence that in addition to improving glucose compartmentalization, that it may actually improve renal function. And so there are some other natural molecules that could be very safe. Nitric oxide is critical. I think I've said it enough, but nitric oxide is critical for the kidneys. Critical. So the question is not which peptide lowers creatinine, which interventions improve vascular biology, endothelial health, autonomic balance, metabolic flexibility, and microcirculatory resilience. So and then you got to focus on the environment, glycocalyx, endothelium, nitric oxide impairment, autonomic imbalances. And so from my perspective, at least, and when I've listened to talks from renal specialists who use peptides in practice, GLP-1s, if the appropriate, are a first line. And then BPC 157 commonly comes up. It comes up for everything these days, but it commonly comes up for anti-inflammatory. There are not other peptides that we would say are specifically renal specific. If there are immune-mediated inflammatory issues, then thymosin alpha, pulses of thymosin alpha could be appropriate, helping with that potentially. TB500 could be helpful, but we can't say for sure. But at his age, if he's training, then he might end up using some cycles of TB500. But again, proceed with caution and monitor response and assess response. But the GLP-1, again, depending on what dose, could be very helpful for this person and from the standpoint of a peptide. Now, this is actually kind of going even, well, no, this is the same one, sorry. So again, there's a lot here, right? But at the end of the day, I think on this, it's going to give you a lot of what you need to understand about which tests you would order, how you're looking at that endothelium and glycocalyx, your triage. I had it create an 8 to 10 page, more detailed, because this is bread and butter and comes up so often that I thought, and if y'all want, I will share that one too, once I've had a chance to do my own edit and review on it.